Hello, so this is, again, me studying for the CADC. This is on Pharmacological Addiction Counselor.
Welcome to the Addiction Counselor Exam Review. This presentation is part of the Addiction Counselor Certification Training. Go to https:/www.allceus.com/certificate-tracks to learn more about our specialty certificates starting at $149. Welcome to today's edition of the Addiction Counselor Exam Review podcast. This is episode 22, and today we're going to be talking about pharmacology. We're going to review symptoms of intoxication and withdrawal of drugs of abuse. We're going to learn about post-acute withdrawal syndrome. We're going to talk a lot about that. And we'll identify factors that impact symptomatology. So in general, the purity of the drug is going to impact the symptoms, the speed of the effect, the intensity, and the range and intensity of negative consequences and its effects. Because if you get something that is diluted down, obviously it's not going to be nearly as powerful as something that's pure. The hydration levels of the person. A lot of drugs are responsive to people's hydration levels. So if they're dehydrated, then they're going to get a more intense reaction than if they're not. The route of administration. If people inject, it goes in a lot faster. Inhale, it goes in faster, and oral is the slowest. And usage patterns. If somebody uses every once in a while, they may get a really intense effect. If they're a habitual user, they may have started to develop tolerance, so they may not have the same effects as other people. And we're going to talk about tolerance and sensitization later in the podcast. So remember that injecting can result in blood infections, collapsed veins, and kidney and heart problems, even though that's the fastest method of administration, getting it to the brain. Inhalation can result in ulcerated nasal passages and, other problems in the sinus cavities. Oral ingestion, drinking, eating, must be filtered through the liver and the kidneys, and it often also irritates the GI tract. And this is the slowest method of administration. So take marijuana, for example. People who smoke it feel the effects a lot faster than people who eat it, who may not feel the effects for, 45 minutes or so. Same thing with LSD. LSD doesn't typically take effect right away. It's like 45-minute lag time. So people tend to think, it's not working, and they take more, and then they end up overdosing. So let's start out looking at some of the drugs of abuse. Alcohol is classified as a sedative, hypnotic, and a CNS depressant. Now, the interesting thing with alcohol is the initial stage when people are buzzed or intoxicated, it is more of a sedative. It tends to lower disinhibitions or lower inhibitions. But as it starts to wear off, it wears off faster than the body can start making GABA again. So people start to feel anxiety, and a lot of people will start to feel an anxiety or a panic attack when that alcohol starts to wear off, which leads them to take another drink. So it is important to recognize that alcohol has some really interesting effects in the body. There are 8 stages of intoxication as blood alcohol increases. You have your subclinical, which, you're not really feeling much. You have your euphoria, where you're feeling pretty buzzed. Excitement, and then excitement and confusion, then confusion and stupor, coma, and death. So obviously it takes a lot to get to coma, but you can do it, especially if you're doing shots or other things that, you're ingesting a lot of really high purity alcohol really quickly, and if you're dehydrated or haven't had anything to eat. Men tend to drink more than women, but women are more likely to develop drinking problems and experience alcohol-related organ damage at lower levels. This is because women's blood alcohol reaches higher levels with the same amount of alcohol as men, because alcohol mixes with water, and men tend to have more body water. They have more muscle mass, which means they tend to have more body water. So it is important to recognize that it's the blood alcohol we're looking at more so than how many drinks did the person actually have. Alcohol-related medical conditions, loss of control of eye muscles or nystagmus, and people may be looking at you, especially if they're intoxicated and their eyeballs are kind of darting back and forth. Hypoglycemia, so if somebody is diabetic, alcohol is really a dangerous thing because it's going to start messing with blood sugar. Gastritis and pancreatitis, it really starts upsetting the stomach and the pancreas, as well as the liver. All of those digestive organs get hit pretty hard with alcohol, and alcohol increases the level of, or the risk of, a lot of different cancers, including stomach and bladder cancer. But I digress. So reduced immunity, cardiac arrhythmia, especially, initially you have that sedative effect of the alcohol, so heart rate may slow down a little bit, but then when it starts to wear off and the body can't keep up, substituting what the alcohol was doing with GABA, the person may start to feel like their heart rate is beating really, like their heart is beating really fast, or they may have arrhythmia, which is irregular heartbeats. People may have anemia because alcohol inhibits the absorption of certain vitamins and minerals. They may experience constant flushing, peripheral neuritis, fatty liver, cirrhosis of the liver, increases in blood pressure. Now, I really want to focus on this because people who are detoxing from alcohol, remember I said, I know, I've said it like 5 times now, the body can't keep up. So when somebody starts detoxing, they tend to have a stress reaction. So you have anxiety, you have faster heart rate, you have an increase in blood pressure. Someone who has been drinking a lot, if they decide, even if they're not a quote problem drinker, if they drink a lot and they decide to suddenly detox themselves, that can be dangerous. Alcohol detox is one of the few drugs that is actually life-threatening to detox from. So they need to be under supervision because their blood pressure can go really high really fast. They also may have inadequate absorption of certain B vitamins, which can lead to something called alcohol-related dementia or Wernicke-Korsakoff syndrome. If somebody who is detoxing suddenly starts slurring their words and acting like they've got dementia or some sort of cognitive impairment, it is a medical emergency. It's not just going to improve as soon as the alcohol wears off. If it is Wernicke-Korsakoff syndrome, they need to get to an emergency room and get an injection of certain vitamins in order to prevent this from becoming permanent. So, there's my little spiel on alcohol. Cannabis. As of 2016, cannabis is still considered a Schedule I drug by the DEA. Schedule I substances have no medicinal use and a high risk of abuse. Now, I'm not going to argue whether there's medicinal use or not. I'm just telling you what the DEA says, okay? So, cannabis is legal in 29 states for medical use, despite what the DEA may say. And in 8 of those states, it's also legal for recreational use. So it's Schedule I, but we've got a lot of laws that kind of contradict that, which leaves a lot of room for people who have substance use issues to minimize, justify, and deny they've got a problem because they can point to case law and regulations. 9 to 17% of occasional users of marijuana become addicted, and 20 to 50% of daily users become addicted. So yes, cannabis can be addicting. Methods of administration of cannabis include being smoked, consumed, smoked or consumed. Smoked, it can be smoked in pipes, bongs, blunts, or even through dabs, and that is the more rapid action. If people drink it in tea or eat it in brownies, there is a slower mechanism of action for the cannabis with those. Cannabis acts on cannabinoid receptors, which influence memory, pleasure, concentration, and sensory perception. So let's talk about dabs for a minute, because those are more popular now than they were 20 years ago. Dabs are concentrated doses of cannabis that are made by extracting THC and other cannabinoids using a solvent like butane, carbon dioxide, or other things that results in a sticky oil. If you've ever seen the sap that comes out of like a pine tree, that's kind of what we're thinking about here. Even when home extraction goes well, there's no way to know the quality or purity of the finished product. Dirty oil can contain chemical contaminants, so it may still have some of that butane or carbon dioxide stuff in it, or excessive amounts of residual solvents that could present health hazards. So is it safe? Yeah, the jury's really still out. Cannabis extracts often test between 60 to 90% THC, which means it doesn't take much at all to become profoundly high. It can be inhaled using a dab pen or an e-cig with certain attachments. So if you've got clients that are vaping, you do want to be aware of exactly what they're vaping and whether it's cannabis, spice, or tobacco. Besides coughing like a maniac, the second most common side effect associated with dabbing is sweating like you ran a marathon. So if you have a break and clients go out and they have a smoke break or whatever, if you allow smoking in your facility and they come back and one person starts just sweating profusely, that's what we call a clue. Effects of cannabis in general. Respiratory illness. When you're inhaling things that your body's not used to, you're more susceptible to respiratory illnesses. Heightened heart attack risk. Cannabis can raise your heart rate and cause a heightened risk of heart attack. Neurobehavioral effects on a fetus. It happens. Increased depression, anxiety, and suicidal thoughts, especially in adolescence. Loss of motivation, worsening of schizophrenia, impaired judgment, impaired coordination, reduced life satisfaction, and lower academic or career success. So, when we're looking at the physical impact of cannabis, it's not nearly, in my opinion, not nearly as scary as alcohol, which is also legal. However, it is important to recognize that people can get addicted, and there are respiratory effects and potential heart effects from use. People also need to be careful when they get their marijuana or where they get it from, because it can be laced with other things, and we'll talk about that when we get down to the hallucinogens. But it's important, if they're using, let's just say they're using legally recreational marijuana, they need to know that it's clean and it's of good quality. Also, as a little aside, if you watch the video that we've got on our YouTube channel, allceus.com/YouTube, that's specifically on marijuana, you'll learn that there are dozens and dozens of different strains of marijuana, and some make you more euphoric, some make you more sedated. So it's important to recognize that marijuana is not just a plant. It's not like oregano that's pretty much the same. There are different variations to it, and the impact on the person is different. You can also, or growers can also genetically modify and do things to enhance the THC levels in their cannabis plants. So again, even if you're getting the same strain from Jim and then you go over to Sally and buy from her, she may have a totally different intensity of her cannabis. So those are things to be aware of when you're working with clients and who may be using cannabis. Synthetic marijuana, or spice, K2, whatever they call it now. Synthetic cannabinoids refer to a growing number of man-made, mind-altering chemicals that are sprayed on dried, shredded plant material and vaporized to get high. So it can be on oregano, it can be on, just about anything, tobacco, whatever. Synthetic cannabinoids are sometimes misleadingly called synthetic marijuana or fake weed because they act on the same brain cell receptors as THC. But the effects of synthetic cannabinoids can be unpredictable and severe or even life-threatening. There are dozens of case studies of people who used spice or K2 and they ended up having a psychotic episode that lasted weeks. They became extremely uncharacteristically violent when they were in the emergency room. So it can have really odd effects on people. Synthetic marijuana or synthetic cannabinoid users report some effects similar to those produced by marijuana, including elevated mood, relaxation, altered perception, and symptoms of psychosis in bad cases. Synthetic cannabinoids can also cause serious mental and physical health problems, including rapid heart rate, vomiting, violent behavior, and suicidal thoughts, and it is susceptible to hydration levels. There was an incident in Washington, D.C., evidently over the 4th of July, where 140 people were sickened when they were smoking spice. And officials blame it, maybe on a not great batch of spice, but also because those people had been out at a festival all day long and were dehydrated, and that contributed to the effects. And I believe either 4 or 6 people died. But so you can have some pretty negative effects. Signs of stimulant intoxication. So we're going to move on. We've done alcohol and cannabis. Those are kind of in their own categories. Stimulant intoxication is pretty easy to pick out in clients. They will have dilated pupils. So you want to look for those pupils that are like wide open and they don't respond to light. Obviously, if you're in a really dark room, people's pupils are going to be wide open. But if you're in a moderately lit room, look at other people's pupils and then look at the client, and they will be just blown, as we say. They are often restless, hyperactive, may not have an appetite. They may have some weight loss, and they're probably going to be sweating. Think about what a stimulant is. It's something that's supposed to increase your heart rate and get you going, basically mimicking running. So when you think about it, you will have all the effects of being completely wound up and going full bore, but the person may be sitting still. Signs of stimulant withdrawal. Remember, withdrawal symptoms are generally the opposite of what the intoxication symptoms are. So with stimulant withdrawal, the person becomes dysphoric. When they're on stimulants, they may be giddy, they may be excitable, they may be the life of the party. When they are not using, they may be flat and dysphoric. They may have some anxiety or agitation, intense drug cravings, rapid eye movements, concise but quivery speech, brisk but somewhat jerky movements, and their thinking is often scattered and subject to paranoid delusions. So be aware of these. If you're in a detox unit, you're going to have people that may have some paranoid thoughts while they're going through detox, and you just want to watch for signs and symptoms of these that may need to be intervened or mediated before they become a crisis situation. In the middle stages of stimulant withdrawal, anxiety and agitation are followed by a period of fatigue, increasing depression, anhedonia, which means nothing makes you happy, and decreased mental and physical energy. There's an intense desire for sleep, often accompanied by insomnia, and this usually replaces the drug craving. So think about this. You just want to sleep so bad, but you can't because you have insomnia. That really sucks. So this person may start getting frustrated and agitated. During this part of the crash, if they're not in detox, users may use alcohol, benzos, or opiates to induce or prolong sleep. So they try to self-medicate that insomnia. The middle crash phase lasts between 24 and 36 hours, during which any attempt at therapy or other intervention is inappropriate. Even if you've got a client on your wing and they're in this phase, they've got insomnia, they can't sleep, they are not cognitively able to focus and really do any sort of therapy at this point. So we just need to provide them palliative care and get them through the withdrawal phase. Protracted and late withdrawal. The user experiences symptoms that are the opposite of stimulant intoxication. So we're continuing with the fatigue, the loss of energy, depression, yada, yada. The symptoms may increase in intensity over the next 12 to 96 hours immediately following the crash and may wax and wane over several weeks. So that middle period, remember, go back here, the middle period's 36 hours. So 0 to 36 hours, we expect these symptoms. But they may still intensify up to the 96-hour period. So we've still got another 30 hours to go before we know that the person is going to start decreasing in the intensity of their symptoms. But for the next several weeks, because of the protracted withdrawal, they may have periods where they're asymptomatic and then periods where they are symptomatic. So they don't really know from one moment to the next how they're going to feel. A severe and persisting depression in this phase can result in suicidal ideation or suicidal attempts. So you do want to regularly be screening for mood disorders. And remember, we're not just talking about mood disorders that existed independent of the substance use. If someone is detoxing and they hit this period of severe depression, they start sobering up, they realize that they lost their job, they lost their family, and they've got pending legal charges, they may get severely depressed and be suicidal at that point. So if the person is severely depressed for any reason, you really need to pay close attention. The anhedonia and dysphoria usually dissipate over a 6 to 18 week period. Now sit with that for a second. I don't like feeling blah and unhappy and, nothing does it for me for 6 days, let alone 6 to 18 weeks. And this is true with any stimulant, not just methamphetamine. So your cocaine, your crack, any of that stuff, Adderall, it's important to recognize that this is a problem and it will be a relapse trigger for a lot of people. And I always use the analogy of Eeyore. They were feeling like Tigger for, when they were using. Now they feel like Eeyore and just everything is dragging and nothing makes them happy. And some clients report that nothing is not colorful. It's just everything is gray. There are no highs, there are no lows. It's just blah all the time. So think about those days when it's not raining and it's not sunny. It's just really kind of blasé gray all day long. Think about living in that mindset for 18 weeks, okay? So this is why we need to really create a strong relapse prevention plan, and in some cases, with some clients, have them consider talking to a psychiatrist about a short course of antidepressants. Periods of drug craving may reemerge and be triggered by environmental cues, you see it, people, places, and things, and emotional states. So if they're feeling depressed and they have self-medicated that depression with stimulants before, well, guess what? They may want to do it again. If they are getting ready to go to a party and they've got some social anxiety and they used to use cocaine before they went to parties, it may trigger them to want to use again. So we do need to, again, pay strong attention to relapse prevention planning early in treatment. Tolerance. There's tolerance to many of the initial effects of stimulants after only a few weeks of use. So just like opiates, which we're going to get to in a few minutes, people, if they've been using for just a few weeks, they're going to need to use more and more and more. Tolerance develops rapidly to the euphorogenic and anorectic effects of stimulants and weight of stimulants. So let's just stop there for a second. Euphorogenic, which means the happy that you get, you don't get that same happy anymore, which leaves a lot of people doing what we call chasing the high, and they're trying to use more to get that same rush that they got the first time they used. And the anorectic effects, those are those appetite suppressant effects. Those generally wear off pretty quickly too. And weight loss generally stops after several weeks because the person has lost a significant amount of weight, so their base metabolic rate goes down and their weight loss stops. Tolerance also appears to develop to the cardiotoxic effects of large dosers, which means many users who are using something 3, 4, 10 times what they were using when they started can use that and not have a heart attack and die because their whole body has gotten used to having that drug put into it. So it's not as dangerous. Tolerance is a really interesting thing. But you got to remember, a lot of tolerance will go back, wear off, if you will, over time. So you don't want to assume if the person was using X amount when they stopped using, that they can be clean for 6 months and then use that same amount and not have negative effects. So it's really important for people to understand tolerance and the resolution of tolerance in the whole scheme of recovery. So if they do relapse, which I'm hoping they don't, and relapse is not a necessary component of recovery, but if they do need to be aware of the fact that they can't pick up where they left off at that same dose, or it could kill them. Many of the initial symptoms of stimulant intoxication disappear with chronic use. So they could be using methamphetamine and their blood pressure may be normal, and they may not be nauseous or vomiting at all because their body's gotten used to it. The body adapts in order to preserve itself and help the person survive. I told you we'd talk about sensitization. Now, this is the opposite of tolerance. Sensitization is a unique phenomenon of stimulants. Users are especially vulnerable to psychosis-inducing effects. So after one psychotic episode is experienced following use, a lower dose may induce another psychotic episode. So some of the negative effects that come from the use of stimulants, you may experience those at lower and lower doses, but in order to get that euphoric feeling, you're needing higher and higher doses. So you see where there's a problem here. Cocaine users are more likely than methamphetamine users to present with serious and potentially lethal physical complications, including cardiac arrhythmia, chest pain, stroke, seizures, hypertension, and hyperthermia, which means their temperature went up too high. Cocaine users are also more likely than methamphetamine users to use multiple substances, especially alcohol, benzodiazepines, or opiates. And again, think about that middle phase where they're just desperately wanting to sleep but experiencing insomnia. Some people will use the two kind of interchangeably. They use the stimulant to get them revved up for a party, and then when they're ready to go home at night, they use the benzos to come down and go to sleep. So it's really hard on their system. Let's start talking a little bit about hallucinogens, and we're going to start with PCP. Signs of PCP abuse include sedation, immobility, amnesia, numbness, slurred speech and other speech difficulties, a sense of invulnerability, a blank stare, rapid involuntary eye movements. You see those eye movements keep coming up. So if you see that in a client, it's a really good indication that something is going on and you need to probe further. With PCP, you can also experience hallucinations, hence the name hallucinogens. It's important to recognize that with the loss of the sense of self, they may feel intense alienation, as though the world and people in it make no sense, and experience feelings of depression. So if everything that they thought they knew doesn't seem to be the way it was, it gets really confusing. And some people find it cognitively stimulating, and other people it totally freaks them out. People can have delusions, especially delusions of grandeur, when they're on PCP. They have that sense of invulnerability. They think they're God. They think they're the president. But they also may have delusions of persecution. They may think that people are chasing them or trying to read their minds. High blood pressure, rapid heartbeat, reduced pain sensitivity, and apathy. So there's a lot that goes on with hallucinogens that overlaps both alcohol and stimulants. So we need to ferret out what the person's experiencing. Rarely, if ever, I don't think I've ever had a client that has been primarily a hallucinogen abuser who's been self-medicating anything. A lot of times the hallucinogen use starts out recreationally and continues somewhat recreationally. That's not to say it doesn't happen, but just kind of being aware of why your client is using will help you develop a more effective relapse prevention plan. With hallucinogens, low doses are characterized by numbness in the hands and toes, as well as general drunken-like behavior. Moderate doses produce partial or full anesthesia, where the person can't move their limbs or any part of their bodies. They're just like frozen. High doses have the potential to cause convulsions and even death, and it can be added to marijuana or other smoked material. I had a client one time who was on work phase, went out to work, smoked what she thought was spice, and she thought she'd get away with that, but the spice happened to also be laced with PCP. And when she came home, she was experiencing effects similar to a moderate dose of PCP, as well as very intoxicated from the spice. So she had a lot of stuff going on. Her heart rate was in the 190s. She felt like she couldn't move. We ended up having to have EMS take her to the emergency room because she couldn't get off her bed. So there can be very scary or unpredictable consequences. Other symptoms that may show up in a person who's used PCP over a long period of time include stuttering, impaired memory, inability to think clearly, inability to speak, suicidal thoughts, anxiety, depression, and just isolation and withdrawal. Now remember, with the hallucinations, if they start feeling alienated from people, if those thoughts and experiences stay with them, they may start not trusting other people. So they may start socially isolating from everybody else. Now, another hallucinogen that we hear a lot about is LSD or acid. Common signs of LSD abuse include sweating, dry mouth, dilated pupils. Got those blown pupils again. Numbness. Remember, dilated pupils are also common in what? Stimulants. So you can't just look at a person's eyes and go, you took that drug. You do need to do a little bit more exploration. So numbness, dizziness, loss of appetite, tremors, increased blood pressure and heart rate, mood swings, hallucination, distorted thinking, impulsiveness, impaired judgment, and intensified sense of smell and hearing. So a lot of these symptoms of LSD are very similar to symptoms that people are going to experience when they're using stimulants. But this intensified sense of smell and hearing is one that's unique. So we do want to listen for signs of that. And people who use LSD can also experience flashbacks long after the intoxication is ended. So I've heard of people talking about having flashbacks years later. It is important to be aware of. And if your client has ever used LSD, it's important to be aware of in creating their relapse prevention plan, also in creating their treatment plan, and being cognizant if they suddenly have certain changes in treatment. You may want to check in with them and see if they're experiencing a flashback. Many individuals may take LSD and be unaware that it takes between 20 and 90 minutes to elicit its effects. So if you take it and you wait 30 minutes and you don't feel anything, and you wait another 20 minutes and you still don't feel anything, then you take another dose, you may end up taking 2 or 3 times more than you really anticipated, causing some significant negative side effects. With LSD, it's a man-made thing, so doses are not standardized, and it's really important to recognize that one dose that's exceptionally pure or multiple doses in a short period of time can lead to overdose. LSD, like opiates, increase serotonin in the brain. An LSD overdose can produce symptoms of serotonin syndrome, which again is life-threatening. So if somebody has markedly dilated pupils, dangerously elevated blood pressure and temperature, super rapid heart rate or irregular heartbeat, tremors, muscle shakes, extreme drowsiness, nausea, diarrhea, excessive sweating, flushing, goosebumps, those are all things that should be a warning sign that something is not going well. Anytime somebody's temperature is way up, or their blood pressure is way up, or even their heart rate is way up for more than just a second, it's probably worth making sure they get emergency medical care, because that's not normal. and we need to understand what's going on. Another effect of LSD is called rhabdomyolysis, and this is the breakdown of muscle tissue that can lead to kidney failure. And you see rhabdomyolysis in, extreme athletes as well. But the take home is that if this muscle tissue starts breaking down, it can lead to kidney failure. It doesn't matter why it started. So we've covered alcohol, cannabis, stimulants, hallucinogens. Let's move on to those prescription drugs. You have opiates, which rank number 2 behind marijuana as the most abused drug out there. 60% of people who abuse it got it free from friends or relatives. They didn't go to their doc and try to get a prescription. They got it from a friend. Opiates are obviously used to treat pain, but in some cases, they're also used to treat treatment-resistant depression. So I have seen cases where people have been prescribed pretty intense levels of sedative-type drugs, opiate-based drugs, in order to address depression. So being aware of that. Why is the person taking the opiates? Now, this can be why is the person prescribed the opiates, so you understand how to write a treatment plan, or what is the benefit to the person to taking the non-prescribed opiates, because they may be self-medicating. So if they take the opiates, and there are certain opiates that make you feel pretty good and take away that anxiety feeling, and other opiates will tend to knock you out. But if you find out that somebody's taking a particular opiate because it helps them deal with their depression or feel like they've got more energy or feel more relaxed, they're probably self-medicating, so we need to look at that. Another prescription drug that people use are depressants. Generally, your antidepressants are not drugs of abuse because you don't get high from those. But your benzos, your benzodiazepines, and your barbiturates are definitely drugs of abuse and really easily abused. They're used for anxiety and sleep disorders. So you're thinking your Xanax, your Valium, your Lunesta, all those things. And then stimulants are also sometimes prescribed for issues like narcolepsy, ADHD, and obesity. So there are legal uses for opiates, depressants, and stimulants. But all 3 of these drugs, or all 3 of these classes of drugs, are also very easily misused. Prescription and over-the-counter drugs can be abused by taking medication that was prescribed for somebody else. So you're doing it to get high or to self-medicate. Taking drugs in a higher amount or via a different method than intended. So if your prescription is for 1 pill 3 times a day and you're taking 3 pills 3 times a day, that's abusing them. Or if it's for 1 pill 3 times a day and instead of taking it orally, you're injecting it, that's abusing it. Taking drugs for a different purpose than intended. So if you're prescribed a drug for pain, you had oral surgery and you had oral surgery 8 months ago, and then you decide to start taking your leftover opiates, technically that's a method of abuse. And by combining drugs, either of the same class or of a different class, in order to intensify the high. So some people may combine opiates and alcohol. Dangerous, very dangerous. Anytime you combine 2 different kinds of basically system depressants, the addition, it's not like taking 2 doses of something. It's like taking 4 doses of something. So 1 + 1 = 4. So that can be very dangerous. People may also combine things like opiate and amphetamines in order to get a different type of high. So, we want to be aware of these things. Withdrawal from drugs of abuse. Sustained use of addictive substances causes reversible adaptations within the body. Notice I said reversible, not irreversible. So a lot of times the changes that happen in the brain and the body will recover after a period of abstinence and positive health behaviors. During withdrawal, it's important to recognize that people may experience a lack of pleasure because The euphoria producing drugs act on the nucleus accumbens, or the pleasure center of the brain. So this center is kind of overtaxed, and it's kind of like what Target looks like after Black Friday. It's just completely wiped out. So we need to give it time to restock its shelves and get itself back together. And again, remember that alcohol and benzodiazepine withdrawal can be life-threatening. Opiates, withdrawing from them is generally not life-threatening as long as the person doesn't get dehydrated. There are a lot of doctors that will do ambulatory detox for opiates and stimulants, but they won't do it for alcohol or benzos. It's up to your attending physician how to handle those things. But if you're in private practice or you're a mental health counselor and you know of a client who is deciding that they're going to detox from these and they want to self-detox, it's really important to educate them that could be very, very dangerous. So post-acute withdrawal syndrome. This is the roller coaster of intermittent withdrawal symptoms that especially impact mood, sleep, and pain, and can continue after acute withdrawal symptoms have gone away. So a lot of people, if you've ever worked in a detox unit, you know that we bring people in. We usually keep them for 3 to 5 days. If we're talking detox from benzodiazepines, it may be up to 2 weeks. But I've never had a doc keep anybody in detox for longer than 2 weeks. So while the acute phase is gone, the drugs are not in their bloodstream anymore, the person may still have waxing and waning of these same symptoms. Each episode of post-acute withdrawal can last for a few days or a few weeks, followed by symptom-free periods, and can continue cyclically for a year. Okay? Remember that. That's probably going to be on your test. It can continue cyclically for a year. Post-acute withdrawal can be just as intense as acute withdrawal and puts the person at risk of relapse in an attempt to stop the discomfort. So those feelings they felt those first 3 days of detox, 6 months down the road, they may wake up one morning and they're starting to feel those same feelings again with their mood, their insomnia, increased pain, all that kind of stuff. A good initial relapse prevention plan prepares the person for post-acute withdrawal. Each drug has a slightly different post-acute withdrawal syndrome profile, so it's important to educate clients about what they can expect. So if they start having drug dreams or, really bad cravings again, they don't feel like they are helpless. They don't feel like they have fallen off the wagon or done something wrong. They understand that this is coming, and they're prepared for it as much as possible. Pause symptoms, post-acute withdrawal: mood swings, anhedonia, remember that's that Eeyore-like state, sleep disturbances, cognitive impairment in memory, learning, and concentration. So if you've got a client who is in your program and they detoxed 3 months ago, but they suddenly start having issues with memory, learning, and concentration, they're not able to focus in groups, it doesn't necessarily mean they're being, quote, resistant. It probably means they're either experiencing post-acute withdrawal, or something else may be going on in their life, or they've got a co-occurring disorder that has been exacerbated. So any of these things, you do want to consider what is the reason for it. And remember that resistance, or if a client appears resistant, it generally means that we're missing something. It means we're not doing what the client needs us to do, or helping the client to do what he or she needs to do. So anyway, mood swings, anhedonia, sleep disturbances, cognitive impairment, fatigue, drug cravings, stress sensitivity, and lower pain threshold. So this stress sensitivity, and a lot of us have probably experienced it at one time or another when we've just been really worn down, and one more thing, doesn't matter how small it is, one more thing is just going to make us freak the freak out. We've all had those days. Well, this happens during that post-acute withdrawal phase where people may feel like they're just barely hanging on, white knuckling it, as they say, and anything can prompt an extreme reaction. Not necessarily violence, but if somebody leaves the cap off the toothpaste, it may result in screaming instead of just putting the cat back on the toothpaste and having a calm discussion. So in summary, many people are polysubstance users, and that's important to remember. Signs of withdrawal are often opposite those of intoxication, so that's an easy kind of rule to remember. Pupil dilation and nystagmus, the bouncy eyes, are good indicators of potential intoxication from some type of substance. It can also indicate a head injury, so if somebody's been in a car accident, be aware of that. Protracted withdrawal can last for up to a month for many drugs. So, that first month for a lot of people can be really, really rough. And part of that is not only the drug getting out of the system, but the body rebalancing itself after, it's been out of whack for a while. So it takes a little while. Think about, and I use this analogy all the time, running a bath. Maybe you have been running a really hot bath because you like hot baths, and at a certain point it gets too hot and you decide, what, I'm going to turn it down a little bit. So you turn on the cold water, and the cold water is pouring in at your feet. So what do? You swish it around, and what happens? You have hot and cold spots. And that's kind of what protracted withdrawal and post-acute withdrawal are like, because the initial issue, you've quit using, but you're getting restabilized and everything is evening out now. So there could be little spurts or hot spots, if you will. Remember that LSD can trigger serotonin syndrome. So if somebody is taking antidepressants and they have a history of using LSD, or they're taking antidepressants and you find out that they're currently using LSD, that's really important for them to talk to their doctor, because this could be life-threatening. And post-acute withdrawal syndrome refers to the mood, cognitive, and sometimes pain-related symptoms that may persist intermittently for up to a year after somebody quits using. Generally, if people can make it through that first 12 months, it gets a whole lot easier. But we need to give them every tool and access to every resource possible for that first 12 months in order to ensure they make it that far, because it can be really miserable. Alrighty, so that was your summary of pharmacology. If you go to our YouTube channel, allceus.com/YouTube, you can see a lot more videos on pharmacology and much more detail on each of the individual drug classes. This was just kind of to give you an overview. You can also Google acronyms or mnemonic devices to learn some of the different symptoms of intoxication and withdrawal, if that is easier for you to learn with. All right, well, thank you for being with me today, and I will see you next week. All of us at All CEUs wish you great success on your exam. Once you're certified or licensed, please remember to visit All CEUs for all of your continuing education needs. We offer unlimited CEUs for $59 for addiction and mental health counselors, social workers, and marriage and family therapists. If you're still thinking about becoming an addiction counselor, All CEUs offers the training you need in 3 formats: online multimedia self-study plus live webinars, or face-to-face weekend intensives, which meet 1 weekend per month for 12 months. We can even present a training series at your facility. Just email support@allceus.com. Go to allceus.com/ACER. That's allceus.com/ACER to learn more.
Okay, now we're moving on to pharmacology designer drugs.
Hello, everyone, and we're going to go ahead and get started today. Today, we're going to be discussing the pharmacology of designer drugs. Now, this is probably going to be more of an academic class than some of the others. because we're really talking again about the same basic classes of drugs, your stimulants, your depressants, and your hallucinogens. From a treatment perspective, however, as a facility director or a clinician, it's important to understand what drugs are out there, what drugs are legal, that clients may still be using and abusing. And if you've worked in the field for a while, you're probably well aware that they will, clients that is, will use anything to get a high, from nutmeg to toothpaste to spice and other drugs. So if they want to get high, they're going to get high. It's more important to understand the reason they're needing or wanting to use, as opposed to specifically which substance. Although the type of substance, whether it's a stimulant or depressant, may give you a clue to the underlying issues. So with all that being said, let's go ahead and progress. Let me see. Let me get the chat window up. Perfect. So if you have any questions, remember, you can feel free to send a message through the chat window at any time, and I will try to answer it as quickly as possible. So we're going to review the pharmacology of alcohol. We're going to do that really quick because, we've kind of belabored alcohol quite a bit. I will be putting a really good article that was written by somebody at the University of North Carolina School of Medicine that talks about the pharmacokinetics of alcohol. If you really want to get down into the weeds on how alcohol works and how it's reinforcing and how it works with the dopamine, opiate, and the GABA systems, more power to you. We're going to define designer drugs because that's kind of a garbage term that's thrown around. We will also review the effects of some of the most common designer drugs, identify which designer drugs may still be, quote, legal, because in a treatment center, we tell them, obviously, you can't use anything that's illicit or mind-altering. But a lot of clients will try to find that little loophole and say, well, it's legal, so you can't prevent me from using it. Well, alcohol is legal, and I can prevent you from using that if you're in treatment. So, let's talk about, again, why you are needing or wanting to use that during your recovery period. But also understanding that those that are legal are going to be a lot easier for your clients to access when they go out on work phase, if you're doing an IOP program, etc. And then we'll also discuss ways of handling legal drug use in your programs. And we'll just kind of go from there. One thing I did want to show you, and let me see if I can do this without completely making everything go wonky. There we go. One of the best or two of the best resources to find the up-and-coming drugs, the ones that you need to be worried about if you work in a correctional facility, if you work in a residential treatment center, or even if you just work with persons with addictions and co-occurring disorders, is Police One and Corrections One. These are two websites that are dedicated, obviously, to law enforcement and corrections to help them stay abreast of what may be getting brought into their facilities as contraband. They will be on the leading edge of a lot of the new designer drugs that come out. There are literally hundreds of designer drugs and things you can get high off of. It's just a matter of kind of narrowing it down to what your clients are using in your particular area and becoming more informed about those as well. So alcohol indirectly activates the dopamine and opioid systems, which produce the reward. When people drink alcohol and they are in a social situation, they may feel more relaxed, more sociable, more energized. When they're not in a social situation, they may feel more relaxed. Either way, and again, you can get down into the weeds on the pharmacokinetics of this, but the dopamine and opioid systems are activated. Alcohol also antagonizes GABA. Now, you remember, antagonize means it's a big old bully and it shuts it down. So antagonizing GABA, which is our relaxation, is what causes the jitters and the anxiety and all of the symptoms that we see in withdrawal from alcohol. As those depressant and rewarding and calming effects wear off, the GABA is being antagonized, so you've still got too much glutamate in your system, which is your get up and go chemical. So the person starts to get higher blood pressure, tachycardia, all those sorts of things. The nice thing, if you will, in detox, benzodiazepines, we use Librium a lot, can be used and really effectively helps moderate that system and helps relax the person enough to keep them from having a stroke or a heart attack or anything like that. So there is an NIH article on the pharmacology of alcohol that will be in your class when you go in there. If you want to read about the pharmacology, it's one that's written kind of on a journal level, so it's not an easy read, but it is definitely informative, and it's not too hard. It's not like reading People magazine. It's going to take some concentration. So designer drugs refer to drugs that are created in a lab. That's all it means. It doesn't mean it's the most common or the most popular. It just means it's created in a lab. The downside to this is most of your designer drugs are not created in a lab like Eli Lilly. They're created in a lab in somebody's basement or in somebody's backseat of their car or in somebody's trailer, which means it has a lot of adulterants, and the quality control, the amount of the psychoactive substances in each batch likely varies quite a bit. So designer drugs are those that, can actually be more dangerous than some of your other, quote, natural drugs. For example, marijuana. We know that your average marijuana plant is going to have a certain amount of THC in it. It used to be 5% THC. Now we're up around 15 to 30% THC because of selective breeding practices. But we know that any marijuana coming from XYZ plant is probably going to have about this much THC in it. And that's not alterable nearly as much as something that's just created in the lab. My kids hate it when they come try to help me in the kitchen and they're trying to learn how to cook. I don't follow recipes. I'm like a pinch of this, a dash of that. Let's just do a sprinkle. Some of your people who are making designer drugs kind of work on that same, perspective. So, just let clients know that it is important to be aware of it. One other thing I found when I was doing research for this class was that there are some fake hydrocodone tablets that are out on the market now that are actually laced with fentanyl. Remember, fentanyl is 30 to 50 times more powerful than morphine or than heroin. So if somebody's taking hydrocodone, which is relatively weak compared to those drugs, and they get something that has fentanyl in it, it could be deadly. Anyhow, there is a DEA booklet on drugs of abuse. It's like 80 pages, and it goes through the most prominent drugs of abuse, what they look like, what their street names are, some of their effects, yada, yada, yada. The NIH drugs of abuse chart will pull up, and it's very similar. And you can do the drop down, tells you your street names, commercial names, common forms, common ways taken, what DEA schedule it is. We don't really care at this point. We know that we really don't want our clients taking ecstasy. Possible health effects and treatment options. If there are medication-assisted treatments available, it will be listed here. For example, alcohol. Well, of course, that's not going to have it there, but you would think they would have antabuse and some other things listed there. Anyhow, so back to the PowerPoint. Bath salts. This is one of the most misunderstood by old fogies like us, or me. I don't know how old y'all are. When I first heard of bath salts, I was like thinking bath salts, the Epsom salt things that you put in your bath. Has nothing to do with bath salts. They are synthetic catheones, which are drugs that contain one or more synthetic chemicals related to the cathione family, which are stimulants found in the cat plant. So they take this cat plant and they extract the chemicals from it, or they make synthetic chemicals that resemble it, and then they put it into other stuff. These synthetic catheones are cheap substitutes for other stimulants such as methamphetamine and cocaine. So remember, like fentanyl is a really cheap substitute for heroin. Bath salts are a really cheap substitute for cocaine. Products sold as Molly or MDMA, it's actually called herbal MDMA, often contain synthetic catheones instead of the real ones. Bath salts are typically swallowed, snorted, smoked, or injected. So, however you want to take it, people are taking it that way. And it is not at all related to actual substances that are put in the bath. So, synthetic catheones can cause nosebleeds. Partly, well, if you're snorting it, partly because of that, but it can also increase your blood pressure enough where it causes your nose to bleed. Dilated pupils. Pupils are one of our best tells, if you will, when we have a client come in, if they've got nystagmus, their eyes are bouncing back and forth, if they've got dilated pupils, or if they've got pinpoint unreactive pupils, we have a good idea that they're under the influence of some sort of substance. So pupils are a good thing to look at, especially in somebody that you don't have a baseline knowledge on what their behavior is like. Paranoia, increased sociability, increased sex drive, hallucinations, panic attacks. Remember, this is a stimulant. It's going to have the same effects as most stimulants. However, since they are synthetic and we can't control the quality and we can't exactly control what the chemicals are, bath salt chemicals will differ between different batches and different producers. It can cause violent behavior, kidney failure, liver failure, and suicide. Increased tolerance for pain. This is important for us to know. It's important for law enforcement to know, because if somebody starts having a paranoid psychotic episode and they need to be restrained to some extent. Now, I don't know if you use any sort of actual physical restraints at your facility, but if law enforcement has to come, they probably need to know that Jim Bob may be on bath salts, because the taser often doesn't work. They need to be aware that Jim Bob may put up quite a fight. Not saying that we really want to tase him, but it may be a futile effort anyway, but it will take a lot more effort to subdue Jim Bob if he's having a bad trip on bath salts. People also may get hyperthermia, causing them to tear off their clothing to cool off. So again, this is not a normal behavior that we're going to see in anyone. If you have someone that is like actively tearing off their clothing, you probably can guess. First guess would be bath salts. That's one of the more common reasons that somebody is going to do that. Or they took ecstasy. We're looking at a variety of different things. Depression or suicidal behavior can last even after the stimulatory effects of the drugs have worn off. So you have all your happy chemicals and they gush through, then when they wear off, you crash. And this depression and suicidal behavior can go on for quite a while. How long is quite a while? The research doesn't really say. My guess is it really depends based on the individual and whether they had pre-existing depression or anxiety issues. Bath salts usually look like white or brown crystals, like a powder, and are sold in plastic foil packages labeled not for human consumption. You can see how well we listen to that. Sometimes labeled as plant food, jewelry cleaner, phone screen cleaner, or keyboard cleaner. Popular types of street bath salts include Ivory Wave, Purple Wave, Vanilla Sky, and Bliss, but there are literally hundreds of different producers and different names. We'd be here all day. Brand names to be aware of, one that we've heard a lot about is Flocka, but there's also Bloom, Cloud9, Lunar Wave, Vanilla Sky, White Lightning, and Scarface. Why is this important? Because like I said, each manufacturer has their own special little recipe. You're going to have a better idea about what to expect as far as reactions if you have somebody come into your facility and they say, I just used, bath salts, the Flocka bath salts, you're going to have an idea about what that's going to look like versus some of the others. So Kratom, I'm not even going to try to pronounce the plant, but it's also known as Kratomum, and it's a tropical tree in the coffee family native to Southeast Asia. So I'm like, oh, coffee, cool. I like coffee. It's a stimulant at low doses. And in Southeast Asia, some people chew the leaves in order to get the stimulant effects. At high doses, it's a sedative. Now, there are some people who want to keep this legal because they believe it helps with opiate withdrawal. Well, it's actually a mu opioid receptor agonist, just like morphine. So it may not be as intense as morphine, but you're basically taking an opiate. So whether you're actually detoxing from it or not, or just doing that kinder, gentler step-down detox, we could argue those different points. Many people report that Kratom is an effective treatment for arthritis, restless leg syndrome, and fibromyalgia. Go figure. Something that is a painkiller is going to be helpful for these things. The effects occur within 10 minutes of ingestion and may last for up to 5 hours. So if somebody is having a bad trip, it's only going to last for about 5 hours. But you also know that when they take it, it's not something that's going to take 30 or 45 minutes to take effect. It's going to be in their system, bing, bang, boom. The Kratom plant is currently legal in all but 4 states. So it's important to recognize that you can get this plant, and a lot of times it's sold as cuttings or seeds at tobacco shops, those sorts of places. It's not something you're going to find at your local Home Depot, but it is legal. Long-term use produces anorexia, weight loss, insomnia, skin darkening, dry mouth, frequent urination, and constipation. So you're having, especially high uses, you're having some of the effects of the opiate, of the depressant, because we know that opiates tend to cause dry mouth and constipation. Withdrawal syndrome include hostility, aggression, emotional lability, and jerky movements of the limbs. Khat is a highly addictive drug categorized as a stimulant that creates feelings of euphoria. Khat is taken orally as a tea, chewed into a paste, smoked, or sprinkled on food. The leaves, twigs, and shoots of the khat shrub are most commonly chewed and stored in the cheek, kind of like tobacco. It's a stimulant. You're going to have, potentially physical exhaustion after you take this because you were on a stimulant, just like if you took methamphetamine or, amphetamine or ephedra or any of those. Once it wears off, it's like you've been driving your car with the pedal to the floor and running it in the red area. So the engine needs to kind of cool down for a while. Breathing difficulties, constipation, tachycardia, hallucination, manic behavior and hyperactivity, increased alertness and concentration, and increased motor activity. Long-term effects: high risk for heart disease and cancer of the mouth. These are the ones that are going to be more important to point out to a lot of our clients. Tachycardia may be a long-term effect. Moving on to dextromethorphan. This is in NyQuil. This is in most of your cough suppressants. Your Robitussin DM, the D stands for, guess what? Dextromethorphan. In high doses, and I'm talking really high doses, it's a dissociative anesthetic. At lower doses, it's a cough suppressant and generally lasts about 6 hours. Lately, especially among teenagers, the trend has been to take it rectally through an enema in order to increase the high because it's absorbed more quickly into the system. And, as far as how popular or how new are some of these drugs, these are some of the older drugs that have been around, somewhere between 5 and 15 years. Not all of them are popular in every single state because a lot of people go with what they know. They're going to go with Molly and they're going to go with Ecstasy. They're not as likely to go with some of the lesser known drugs if they can get their hands on the easier drugs. Supply and demand, if you will, or easy access, whatever you want to call it. The trend with dextromethorphan has caused several states to actually move it behind the counter, so people who don't abuse it actually have to jump through all kinds of hoops to get it, when we know that people who do abuse it are going to get it anyway. So, my own little soapbox. Effects of dextromethorphan. Okay, there's a whole lot of them. One of them, remember I said the eyes are our clue, nystagmus, that rapid eye movement. At higher doses, maybe there when people take dextromethorphan. Lack of coordination, nausea, dizziness, hallucinations, impaired judgment. The other thing to consider is, how many of these symptoms or effects, if you will, are because you're taking toxic doses of a synthetic medication. Altered perception, altered time perception, feelings of floating, visual disturbances. It's a hallucinogen. It's going to have very similar effects to your other dissociative hallucinogens. Salvia Divinorum is a hallucinogenic plant native to northeastern Mexico. Now, at least when I was in college, and, that was a while ago, people would smoke salvia. The interesting point, and the point that I think a lot of people don't really realize, is there are many, many, many salvia plants, and salvia is the taxonomic name for sage. Most of the salvia plants don't have the hallucinogenic effects. So if you go out into your grandma's garden and cut some of the salvia out, you're probably not going to have any effects, or any you do are just going to be placebo effects. It's sold at many tobacco shops in seeds, cuttings, leaves, and extracts, and is not currently controlled in the United States. The other thing to watch out for is if your treatment program has a gardening component to it. Be aware of what some of these natural plants look like, so you know if your clients are sneaking in seeds and growing them, because they do, and they will, and you just have to be able to identify them and get rid of them. Anyhow, salvia leaves are smoked, chewed, or vaporized. So you can take the substance from the salvia plant and put it into the vaporizer, take the warm air through it, the warm moist air through it, and inhale. DEA fact sheet on that. It can produce intense hallucinations such as floating or flying, and heaviness or lightness of the body. Now, one interesting thing here is I've had a couple of clients who have taken spice, and one of the side effects that they reported from their experience, which both of these clients in question had really bad experiences, was that they felt like their body weighed 1,000 pounds. They could not move because of the heaviness. Which leads me to question whether the Salvia Divinorum was actually one of the herbs that was in the spice that they consumed. Because we'll find out in a little while when we talk about spice, that spice is just a bunch of herbs that are all crushed up, and then they spray the synthetic THC on it. So you don't know exactly what you're smoking that has been coated with synthetic THC. Less intense effects of the salvia occur only when the eyes are closed, include visual hallucinations. There can also be dizziness and nausea. I get motion sickness at the drop of a hat. I can look at a car and get motion sick. So I can't imagine feeling like I'm floating or flying and close my eyes and not get nauseous. But lack of coordination, slurred speech, awkward sentence patterns, decreased heart rate, and chills. And we're going to move on to spice, which is also known as synthetic cannabis or synthetic marijuana, fake pot, legal weed, herbal incense, and potpourri. Again, the active ingredient, the synthetic marijuana, is sprayed onto the crushed up herbs. So you don't really exactly know what you're smoking. It could be rosemary, it could be clove, it could be salvia. You just don't know. Natural marijuana gains its mind-altering effects from a chemical known as THC. Synthetic marijuana, on the other hand, is coated with synthetic cannabinoids. Over 700 different chemicals fall into this category. 700, which explains why it was so hard, and it is still so hard, to test for spice in a urine screen. Because you would have a panel as big as the room trying to figure out what somebody had taken. These chemicals are similar to natural cannabinoids found in marijuana, THC, but affect brain receptors differently. So it's important to remember that it's chemically similar, but it doesn't activate the same brain receptors. So people who have smoked pot in the past and are expecting a similar experience when they smoke spice are generally very disappointed. Some synthetic cannabinoids are 100 times stronger than THC and operate on other brain receptors beside your endogenous cannabinoids. So you have cannabinoid receptors in your brain. THC works on those. These synthetic cannabinoids work on those, plus some other things. And the other things could be anything from dopamine to opioids to GABA or glutamate, depending on which one of the 700 chemicals it is. Significant negative side effects, including high blood pressure, blurred vision, heart attack, vomiting, seizures, hallucinations, and severe anxiety or paranoia. See, I could really work for a pharmaceutical company and do their commercials because I'm good at this negative side effect thing. Anyway, I digress. It's some wicked stuff. There are a lot of people who try spice and will never try it again. I was working with a client who had smoked weed in the past and had been clean for quite a while and then smoked weed again. The weed she used to smoke was, your old-fashioned, like 5% THC. And the new weed she smoked, my guess is from her description, was probably more like 20%. She's like, I thought I was going to die. I was never going to do that again. Now that's going, that's 4 times stronger, from 5 to 20. This goes from 5 to 100 times. It's like, wow. Significant negative effects. We've talked about liquid forms of spice or K2. If you were in the marijuana class, you know that marijuana resins are being extracted, or THC resins are being extracted from marijuana now. There are also liquid forms of spice or K2. Because remember, the synthetic cannabinoids are actually just a liquid that is sprayed onto various plant material. So instead of spraying it onto plant material, let's just give you the liquid. The variety of chemicals may be greater. Some suspect that a few brands of liquid spice may contain traces of synthetic psychedelics. So it just ups the ante a little bit on what the experience may be like and how bad of a trip somebody could have. But there's no way to know. It's not like you can read the label and go, oh, this has 2-CP in and I'm not going near it. K2 alternatives are now out that are legal, but their chemical composition variety varies widely. The manufacturers, the people who make spice, are constantly trying to stay one step ahead of the DEA, one step ahead of the FDA. So they're changing the chemical structure of this drug, of these synthetic drugs, in order to make them so they are not on that controlled list. Foxy Methoxy. I had to include this because I just wanted to say it. Foxy Methoxy is a hallucinogen. It's typically available as a powder, capsule, or tablet. The tablets sometimes are embossed with logos such as a spider or an alien head. And you're like, why do I care? Well, if you are doing a property search and you come across something that has a spider or an alien head and you go to drugs.com to try to figure out what it is, it's probably not going to show up. So knowing that Foxy Methoxy has a spider or an alien gives you a heads up so you have an idea about what it might be. The users feel effects 20 to 30 minutes after administration. It's usually taken orally. Peak after approximately 60 to 90 minutes, and it lasts for up to 6 hours. Remembering that it's a pretty potent hallucinogen. The person will experience dilated pupils. There are those pupils again. Visual and auditory disturbances, nausea, vomiting, and diarrhea. You've got your hallucinations, talkativeness, emotional distress, diminished user inhibitions, pardon me, and jaw clenching. This is one that's kind of unique to Foxy Methoxy and a couple others. So along with the dilated pupils, if somebody is clenching or their jaw or grinding their teeth, or they've got a popsicle stick that they're chewing on, it's a clue that they're probably on something that they're not supposed to be. Ephedra or ephedrine, still legal in certain formulations. There was a big uproar several years ago, because people were taking supplements in order to work out, Stacker 2, Ripped Fuel, and a few others that contained high levels of ephedrine. Now, ephedrine by itself is a powerful stimulant. Ephedrine with caffeine or aspirin is like wicked powerful. And it was causing a lot of negative cardiac reactions. It's an intense stimulant, and it has also been touted as a safe and legal form of ecstasy. And I just went on to Google, and I looked to see, I just Googled, buy supplements with ephedra, and, you can buy them off the internet. Now, the effect of these drugs definitely does vary by the person, by their body weight, by pre-existing conditions, by medications they're taking, how much they take. There's a whole host of things that'll affect how something affects someone. But by the same token, if somebody has had, let's take hallucinogens. If somebody takes a hallucinogen and they've had good trips before, it doesn't mean they're always going to have a good trip. They can have a bad trip. So I don't want people to get complacent and say, well, I've used this before and it's safe for me. If we're talking designer drugs, I would say probably nothing's safe. Now, ephedra is one of those that's actually, if you buy it, like on Amazon or something, is going to be manufactured in a lab. But it is important to recognize and review the research on the fact that it has caused a lot of cardiac events. Alpha-methyltryptamine, or AMT, is a psychedelic and a stimulant. Initially, it was developed in the 1960s as an antidepressant. So we're going to wake them up and we're going to give them a really good trip, and then they won't be depressed anymore. No, it didn't work so much. It creates feelings of euphoria and hallucinations similar to MDMA or LSD. Now remember, MDMA is ecstasy. It is still legal in Canada and the UK, so you can buy it online under the guise of health supplements. It was permanently classified in the United States as a Schedule I narcotic in 2004, though. So you're not going to get it legally in the United States, but if you order offline and get it from Canada or the UK, if it clears customs, it's not that hard to get. Ecstasy has a lot of different names. Ecstasy, X, MDMA. It's another amphetamine-based hallucinogenic drug that's taken orally, usually in tablet or capsule form. So again, we've got hallucinations plus a stimulant. It lasts 3 to 6 hours, increases the chance of dehydration, hypertension, heart or kidney failure, increased body temperature, more pulling at the clothes to get cooled off. Long-term effects can include confusion, depression, sleep problems, anxiety, paranoia, and loss of memory. Now, long-term doesn't necessarily mean permanent. However, when we look at these, you got to think about the neurotransmitters that are being turned up or turned on when you take a stimulant. So again, you're happy, you're running at 1,000%, and then you crash. Depression. When you crash and you sleep for too long and you get your circadian rhythms out of whack, you can have sleep problems. Anxiety and paranoia can be precipitated by insufficient sleep in addition to pre-existing conditions, and or just, again, mucking with that GABA system. Herbal ecstasy, also known as Molly, is caffeine and ephedrine. It comes in pill form and is usually taken orally. It's often referred to as Cloud 9, Molly, rave energy, or ultimate euphoria. Molly is a term that I used to hear a lot when I worked in the treatment center. So ultimately, drugs of abuse are used for one or more of 3 reasons. People either want to relax, go to sleep, the depressant effects. The term depressant is so misleading because it usually doesn't make people depressed. Depressants, when people take them, typically cause that relaxation, get rid of the stress sort of feeling. Stimulation, which is why you would take an amphetamine, or hallucination. You just kind of want to break from reality. All of these drugs were created to mimic the effects of other substances. The list of substances of abuse is never ending. Like I said, nutmeg, if taken in high enough doses, is a hallucinogen. My ever so resourceful teenage clients used to save the orange rinds when they would have lunch, put toothpaste on them, put them in the window. It would dry out. Then they would break it apart and they would chew on it. They would get a high from it, but the high is speculated to be more from fluoride toxicity than anything else. So people will get, we had to take hand sanitizer out of the clinic because people were getting to it and trying to drink it. If somebody wants to get high or if somebody wants to escape, they will. What's more important is understanding what's motivating you to do this. What is the benefit to you of using this particular drug at this particular time? Most of our clients are polysubstance abusers, which is why I say this particular drug at this particular time, because they may have different reactions or different drug choices for different situations. They may use some drugs in order to help them loosen up and be more sociable. They may use some drugs to help them relax. They may use some drugs to help them sleep. And they may use some drugs when they just want to chill out and have fun. Helping them identify why they're using. And, theoretically, if they're in treatment with us, they're wanting to figure out alternatives. Remember that you're not going to get the same effects every time, even on the same person. And you're not going to necessarily experience the anticipated reaction, especially if the person has a pre-existing mental health issue, so their neurotransmitters are already kind of different, or they're taking other medications, and it could be psychotropics, it could be blood pressure medication, it could be a whole host of things. But anytime you start combining substances, you never know what's going to produce Mount Vesuvius. So What questions do you have? When I was preparing for this presentation, one of the things I did was just Google designer drugs, and then I went to the news tab and I looked at what was making news, because obviously those are going to be the ones that theoretically you're going to be more interested in. Remember that some of these drugs can be brought in, like on postage stamps, on envelopes, in very innocuous packages. So not only if you're in corrections, but if you're in a residential treatment facility or even a outpatient, if somebody is bringing, envelopes and stamps and they're allegedly sending letters on break, be a little bit speculative. I hate to say it, but it's true. We need to be a little bit speculative. As far as the statistics with the drugs and the death rates, you can go to the DAWN network. Let me see if I can bring that up real quick. The Drug Abuse Warning Network. And you can go to national data or any of the data tables and look at information about what's being collected. So let's just go to typical day in 2014. It talks about first substance use, alcohol, treatment, emergency department visits. In 2011, there were 845,000 drug-related emergency department visits. Almost 500,000 involved the use of illicit drugs, alcohol in combination with other substances, or intentional misuse of pharmaceuticals. Looking to see if it actually has deaths listed. But it does tell you, alcohol, marijuana, illicit amphetamines or methamphetamine, your MDMA, ecstasy, PCP, other hallucinogens. This is where you're going to find most of your designer drugs, because most of them are stimulant hypnotics. And you can see the majority of them were aged 18 to 25. Well, they were looking at 18 to 25. So if you're wanting to show your clients some hardcore data, you can come to the Dawn Warning Network. You can spend hours going through tables, because I have no life and that's what I like to do, is look at research. But no, I'm kidding. It's actually interesting to look at the trends when you think everything is going up and some things are actually going down. You can get an idea about what's happening. As far as using this information for education, the DARE program does something similar, educating people to the effects of alcohol and drugs and how dangerous they are. What a lot of my clients have told me who were involved in the DARE program was it just basically told them which drugs were safer to use and how to use them. So we need to increase the motivation for students to stay clean, but we also need to go back to addressing the reasons that they're using, as opposed to just looking at the particular drug, because they'll find other drugs. Dextromethorphan sold at Walmart, so kids can go get it if they want it. Nutmeg, probably in your parents' spice rack. They can use it if they want it. And kids have a trend now, and it's been there for a while, that they'll go into their parents' medicine cabinet and just grab a handful of any pills that are there, put them into a bowl, and take a handful and see what happens, which I have to believe they know how dangerous that is, but they don't care. So my question is, why don't they care? Why are they so irreverent about their own safety? Any other thoughts about using it in the public school system as information for health education classes? Okay, well, that ends this presentation. So you can go into the class and take your quiz. And let's see. So I'm wondering,